Welcome back to ST3 Hacks, and in this episode we'll be going through flexor tendon infections and flexor tendon injuries. When this comes in the interview, you should recognize it early as a true surgical emergency, understand the anatomy, and know when immediate escalation is required. Let's dive into the pathoanatomy around this topic. So, flexor tendon infections most commonly occur after penetrating trauma, a feel-on fingertip infection, or bite injuries. The most common organism is Staphylococcus aureus. If the injury is a bite, you should specifically mention animal bites being associated with Tracharella and human bites with Icanella. Infection spreads rapidly because the flexor tendons lie in a closed synovial sheath, which allows longitudinal spread. Now, I should also mention here the important Kanavel cardinal signs, and you should actively look for them and help structure your analysis. So the two signs you see in the patient are fusiform swelling of the finger, and the finger is held in flexion. The two signs you feel are tenderness along the flexor teeth tendon and pain on passive extension. You can mention that not all signs are always present early on, so clinical suspicion remains important. Let's move on to the flexor tendon anatomy. So you should be able to name all the main flexors of the hand. The first three out of the six are FDP, FDS, and FPL. And the second block is lumbricals, flexor digiti minimi, and flexor pollicis brevis. Okay. You should also be aware of the relationship between FDS and FDP. So in the forearm, the FDS lies superficial to the FDP and provides protection. At the wrist, both tendons pass through the common sheath with the FDS superficial to the FDP. In the palm, the FDS spreads over FDP before entering the digital sheaths. And at the proximal phalanxes of the fingers, the FDS forms a campus chiasm, a tunnel-like structure through which the FDP pass through and insert into the base of the distal phalanx. Okay. Moving on, zones of flexor tendon injury. You should outline the zones of injury from zones 1 to 5. Zone 1 is distal to the FDS insertion. Zone 2 is from the FDS insertion to the A1 pulley. Zone 3 is the palm. Zone 4 is the carpal tunnel. And Zone 5 is anything proximal to the carpal tunnel in the forearm. It's important to mention that Zone 2 is traditionally referred to as no man's land because scarring here within the synovial sheath makes repair and rehabilitation really challenging. The thumb has its own 3 zones, T1 to T3. And the best way is to get up an image and kind of go through the things I've mentioned and the image at the same time. The pulley system and the blood supply is also important to know. So there are 5 annular pulleys in the fingers, A1 to A5, and 4 cruciate pulleys. The important ones are A2 and A4, which provide the most biomechanical support. The blood supply to the pulley system comes from vernicular vessels, osseous insertions, tendon sheath vessels, and longitudinal palmar vessels. And lastly, anything distal to the MCP joint is largely supplied by synovial diffusion. Key concerns. You should clearly state that flexor tendon sheath infection can spread into the palmar spaces and lead to tendon scarring, permanent loss of finger function, and systemic sepsis. That is why it should be treated as a surgical emergency. Moving on to our triple assessment approach. So you should start with history, asking about the mechanism of injury, pain using Socrates, and ample history, risk factors such as diabetes, IV drug use and smoking, hand dominance and occupation. These factors influence both urgency and prognosis. The examination, you should do in a look, feel, move approach, look for the Kanavel signs, assess for any open wounds or skin compromise, and exclude a horseshoe abscess, which connects the radial and ulnar bursa through the palm. Investigations, you should ask for a full set of bedside observations. This gives you real-time data on how the patient's actually doing. You should ask for bloods, including inflammatory markers, blood cultures, VBG with a lactate, clotting, and group and save if you're going to take them to theatre, wound swabs if there is a pus or an open wound. If the patient is in septic shock, you should initiate explicitly saying the sepsis 6 protocol. If the patient is stable, you can delay the antibiotics until cultures are properly taken in theatre. For the immediate management, you can say that I would elevate the limb in a Bradford sling, start IV antibiotics if the patient is septic with local antibiotic policy, make the patient kneel by mouth, mark and consent the patient for an urgent flexor tendon sheath washout. You should inform the on-call consultant early and involve anesthetics and CPOD, as this patient will usually require urgent theatre. Surgical management. Now, surgery involves proximal incisions over the A1 and A5 pulleys. This is followed by a washout using saline irrigation, often via a 16-gauge cannula. If there is an associated tendon injury, exploration should be performed under general anesthesia, as flexor tendons often retract proximally. You can then mention that tendon repair can be performed using a 4-strand repair such as the Adelaide technique, which you can look up on YouTube. To get a good grasp of this topic as an overview, I think there are 3 images that you really need to know and understand. The first is the flexor zones in the hand. The next is the flexor pulley system in the fingers. And then lastly is the cross-sectional diagram of the thenar space and the palmar space that shows flexor sheaths connecting in the hand. That's it for this episode of ST3 Hacks, and I'll catch you in the next one.